I have the great pleasure to introduce Dr. John Marshall, who is a professor of surgery at the University of Toronto and an intensivist at St. Michael's Hospital in Toronto. Dr. Marshall has an active clinical research interests in sepsis and intensive care acquired infection, and in the design of clinical trials and outcome measures. He is the founding chair of the International Forum of Acute Care Trialists, also known as INFACT, a global network of investigator-led critical care clinical research groups, and past Secretary General of the World Federation of Societies of Intensive and Critical Care Medicine. He co-chairs the World Health Organization's R&D working group on the clinical characterization and management of COVID-19. Previously, he was the chair of the International Sepsis Forum, the past president of the Surgical Infection Society, as well as the past chair of the Canadian Critical Care Trials Group. Dr. Marshall has published 440 manuscripts, I'm sure there's more than that now, and 85 book chapters, and is the editor of 2 books. He has given invited lectures at more than 540 meetings around the world, and is an associate editor of the journals of Critical Care Medicine and Critical Care. Please join me in welcoming Dr. Marshall.
Thanks so much, and it's sobering to hear how many of those things are past. But I really am deeply grateful for the opportunity to speak today, because as I was thinking, since I was invited, and it was probably over a year ago now, interrupted by the pandemic, about what I'd want to talk about, and as I went back through my own career and what I've done, I was struck, and struck in a way that I didn't appreciate how important it was that the PSI Foundation has been sort of there for me over 3 decades of research, and has been critical to so much that I've done. Not necessarily because it's a foundation that can fund grand schemes, but what it is that it's a body that can support ideas that are in their germinal stages and that need that kind of little impetus to move forward into reality. And I've had a very, really peripatetic academic career with interest in a number of different areas. What I want to do is I want to kind of provide you with some insights into how support from PSI Foundation has been critical to allowing me to move forward and to even, to do things in the first place. And then some thoughts on where we are right now, because I think we are at a transition point in biomedical research as a result of the COVID-19 pandemic. I want to start, though, by giving you a bit of an overview here. I want to take a big picture perspective. John and I were just talking about this. This is a picture taken by the Hubble Space Telescope in April of this year. And I don't know if you can see it, that little red dot in the center is magnified from this image right here. And it is the most distant galaxy that has ever been visualized. It's 13.5 billion light years away from the Earth. So light travels 186,000 miles a second. It's taken 13.5 billion years for that galaxy's light to get there. And more than that, that's only 300 million years after the Big Bang. So we are looking back into time itself. And the reason they were able to pick that image up is because the presence of all the galaxies in the foreground actually caused space-time to be misshapen and allowed an image like that to be taken. So there's a galaxy very shortly after galaxies started to form. There's about 100 billion galaxies in the universe. It's a big, big place we live in. We then live in the Milky Way. This is our galaxy, one of 100 billion galaxies. There's 100 billion stars in the Milky Way. So it does kind of make you feel a little bit small. And just recently, just in the last month, as a result of really unprecedented collaboration amongst scientists, there's now an image of the black hole that is the center of the Milky Way. And so I think I put these forward with 2 thoughts in mind. One is the immensity of the world and the challenges that we face. But the other is the extraordinary power of collaboration, because the Hubble Space Telescope is a multi-continental project. The images of the black hole at the center of the Milky Way required radio telescopes around the world to collaborate with each other to be able to see where we come from. Our world, most of the carbon on our planet is actually in bacteria. It's over 1 billion bacterial species on the planet in virtually every environment you want to look at. Ice in the Antarctic, geothermal vents at the floor of the ocean. And then, of course, our species, there's about 7.8 billion of us on the planet. Each of us has 3.2 billion base pairs making us up in our DNA. So all of that, when you put it together, means that it's complicated, interdependent, and to point to any one little thing as making a difference is to miss the big picture of what the complexity of life and the complexity of this marvelous universe we live in is about. And we've really learned, I think, the essence of collaboration with the COVID-19 pandemic. COVID-19, it's killed, what is it now? Over 6 million human beings have died as a result of this pandemic. It doesn't compare with the influenza pandemic of 1918, 1919, but this is in a world where we have far better resources than existed back then. And governments, funders have been putting money into this. Some funders can put a fair bit of money in. NIH, their budget is over $40 billion a year. CIHR is a fairly small player. It has $1 billion a year. But research is expensive, and what one can accomplish with a small amount of money is not going to be the cure for COVID-19, but it is going to be the mentoring and the enabling of people who can work together to find that cure. And I think that's what's so important. And for me, I mean, this is the place where I spend my life. You know, it comes down to sort of individual patients who are benefiting from that collective knowledge that has been gained through human beings working together. In the ICU, you're dealing with problems which are enormously complex. There is so much that we don't know about so much that is very, very, very basic. And so it's critical that not only we ask all these questions, but that we even have a culture where we recognize that what we don't know is immense, and we need to constantly be researching and challenging that knowledge. And so I really see the PSI Foundation as being the organization that can provide the seed that can allow grand visions to ultimately take shape. So I want to just tell you a little bit about how this has kind of influenced some of my life. I moved to Toronto from Halifax, where I'd started my surgical career in 1990, and my first funding came from the PSI Foundation to do some work on the role of the gut and liver in multiple organ failure. And we had developed an animal model where we could show that when bacteria entered the body through the gut, which doesn't only happen in health, but does happen in disease, it had systemic consequences that resulted in the immune response being substantially impaired. And so this is like a very small contribution to the much bigger understanding of the role that the gastrointestinal tract plays, not just in critical illness, but in multiple diseases. And there's now an extraordinary amount of work being done, for example, on the microbiome and how that's disrupted in critical illness and other disease states, as well as clinical trials that are asking the question, can we restore that? Can we manipulate that? Deborah and Jenny Johnston led the PROSPECT study looking at probiotics in critically ill patients. The Sudoku study is a multinational study looking at whether or not selectively suppressing some of the bacteria that cause disease can improve outcomes for critical illness. So these are all, grand ideas built on individual small fragments of curiosity. So another grant that I was involved with very early on in my career was actually led was the work that Paul Hébert, who's was in Ottawa, is leading in transfusion. It led to a trial called the TRIC trial, but PSI provided some of the important support that allowed us to understand the current structure, the current practice of transfusion in critical illness. And out of that came a trial which has fundamentally transformed transfusion practice around the world by showing that we didn't need to give as much blood as we once did. And even more importantly, it brought a bunch of people together to create this incredible research community within Canada, the Canadian Critical Care Trials Group. And we were talking at the break about how many intensivists there are represented here. Again, it speaks to the power of catalysis. I also had some support from PSI for work looking at the potential role that neutrophils play in critical illness. And what we showed in these studies was that neutrophils in critically ill patients live longer and remain activated for much longer because they subvert their normal tendency to undergo apoptosis or programmed cell death. So if you see neutrophils from patients following trauma or sepsis, they live much longer. And with that funding, we were able to identify some of the reasons, some of the mechanisms through which neutrophils are able to survive longer. We found that there's a whole active program that involves transcription of new genes that then enables the neutrophil to block what would normally be its default position of dying. So in this study, we showed a role for interleukin-1 beta, and that's now gone on. This has been some CIHR-funded research that we have where we've been looking at one particular protein, which seems to be like an on-off switch that determines whether or not these white blood cells live and become activated or are allowed to die. And it all hinges on a single change in that protein, the addition of a phosphate group to one of the amino acids in the protein. So it's opening the door to all kinds of potential targets to turn off and turn on the inflammatory response. We've now got some sort of proof of concept using genetic strategies to knock genes out in mice. We can knock out caspase-8, which is this protein in neutrophils of mice. And when we do that, strikingly, and then challenge the mice with an infection, they do much better if they no longer have that caspase-8. They not only survive longer, but they look better, their lungs look better, and they're better able to clear bacteria. So it's kind of pointing to a really cool mechanism, an on-off switch for inflammation. And so the notion that we could perhaps turn it off more quickly becomes an attractive one in managing critically ill patients. I won't go into this in detail because I know this gets very technical, but we've had support from PSI for studies of a particular gene called PBEF, which is a gene that's found in every species from bacteria up to humans and plays a really critical role in cell energetics. It, at one point, was thought to be a protein that was released from the cell, and so it was given the name visfatin because it's found in visceral fat cells. The paper that did this was published in the journal Science and has the dubious distinction of being the most cited retracted paper in biomedical publishing. This poor group thought that this thing was produced outside the cell, but the support we've had, and these are ongoing studies from PSI, has allowed us to actually discover that what happens with this protein is it's inside the cell where it's functioning as an enzyme, and as an enzyme, the protein interacts with the insulin receptor, and when we manipulate neutrophils by giving them physiologic amounts of insulin, we can modify its function and cause the neutrophils to be restored to a state of quiescence. So again, it's insights that it takes quite a lot of generosity to be able to take those initial steps to try to understand these. Okay, what I want to focus on in the last part, though, is I think in many ways, probably my least successful but most important product of PSI funding, and that was something that has really triggered large-scale collaboration on pandemic research. You recall back in 2009, the H1N1 influenza pandemic, a group of critical care research groups from around the world decided we would try to mount a global research response to H1N1 influenza. We got funding from PSI for a trial called the Collaborative H1N1 Adjuvant Therapy Trial to study the role of statins as a potential treatment for H1N1 influenza. We recruited, I think it was either 6 or 7, I may be a little bit underrepresenting, it may have been as many as 7 patients to this trial, because by the time we had designed the trial, got it through research ethics boards, got sites ready to prepare it, the pandemic had passed and there weren't any more patients around through that. But, and again, this speaks to the critical role of sort of placing the seed in the ground that allows a response to mature in the future. We, coming out of the pandemic, and with some of that support from PSI Foundation, got together to discuss how could we do better at the time of the next pandemic. And what we had a forum that was held here in Toronto, looking at how do you build a research response that is pandemic ready. And we realized it has to be in place before the pandemic need arises. There just isn't time during a pandemic to be able to build a trial infrastructure. And so out of that came the concept that we would, this was the colloquium we had back in 2011. Out of it came the concept that we would start collaborating internationally to create the infrastructure for a response to the next pandemic. In the European Union, the EU provided 24 million euros for pandemic research preparedness, some of which went to building a trial that is now called the Randomized Embedded Multifactorial Adaptive Platform Trial. It was funded in Australia and New Zealand. Canada was late to the game. We didn't get funding in Canada until 2018 for this trial, but it was long enough in advance that we were able to recruit to it. So this is a trial that's running in 361 different sites around the world. We've recruited 11,500 patients. Many of them have come from the United Kingdom, and I'm going to close my talk with a discussion about that. But you can see in Canada, we've recruited almost 800 patients to the trial. Very exciting that this has opened the door for research to be done in places that traditionally haven't done research. One of the highest recruiting countries is Nepal, a low-income country with some trainees who were mentored in Toronto who've gone on and are making a huge difference to the lives of critically ill patients in Nepal. We have participants in Japan, where the Japanese government has really embraced the concept of global collaboration in the response to H1N1. And we've published a number of reports that have really changed the management of COVID-19 in critically ill patients. We've shown, for example, that hydrocortisone improves survival. We've shown that targeting a protein called interleukin-6 increases survival for patients with COVID-19. We've looked at anticoagulation. It seemed to be obvious that if you anticoagulated patients who have a lot of clots, that they would do better. Turns out they don't. If anything, in critically ill patients, they do worse, which underlines the importance of research. On the other hand, for the less severely ill patients, they do better if you provide them with anticoagulation. We looked at convalescent plasma. It seemed to be something that was very promising, and we found that it doesn't really help COVID-19 patients. But intriguingly, if you look at common antiplatelet agents, aspirin and P2Y12 antagonists, there is a signal. And here is our data from the REMAP-CAP trial looking at aspirin and its effects on 90-day mortality. Putting critically ill patients on aspirin actually improves the survival. So we're discussing this now at the WHO because if a drug like aspirin, which is cheap, widely available, can have even a small influence on outcome, this is something that is important to the whole population of the planet and not just to wealthy countries. So this is just a summary of what we've learned so far in REMAP-CAP, and we're using a trial model called a platform trial. That means we have 55 different interventions that we're studying in this. Sites decide which ones they want to study, and we get the answers quickest on the ones that the sites want to study. but we've been able to, in the space of 2 years, generate information on what works, what doesn't work, and what can be harmful. You'll recall very early on that hydroxychloroquine was touted as being the miracle cure for COVID-19. It turns out it kills people. It's not just that it doesn't work, it's actually harmful, and it was important to learn that. Now, I think what's really interesting is that the ecosystem for research has changed, and I don't think it's not going to go back to where we were in 2020. I think the pandemic has alerted funders, it's alerted policymakers to the fact that we can do much, much better in research than we customarily have done. World Health Organization, I've been working with a committee there. We've popularized the concept during the pandemic of a prospective meta-analysis. And what that's actually enabled us to do is to bring together people who are conducting trials in real time to share the data from those trials before they're even published. And so we had something like 85% of all the data from patients who'd received interleukin-6 receptor antagonists available, and we could publish that, and it could get out there and inform patient care much more rapidly. In the UK, they are substantially ahead of most other countries in the world in understanding the role that research plays in driving quality patient care. Back in the early 2000s, they mandated that hospitals would do research as part of the process of providing care to patients. They created the NIHR, and it has proven invaluable during the pandemic. They've recruited something like 50,000 COVID-19 patients to clinical trials, hospitalized patients, and that's why they were by far the largest contributor to REMAP-CAP, because they mandated that British patients who are going to be recruited to trials in COVID-19 would be recruited to REMAP-CAP. And there's a lot of interest. This is the structure they set up so that they could look at ambulatory care, they could look at long post-COVID-19 complications. But it's all integrated into the healthcare system, and it means it's just much more efficient way of doing things. I think Canada has noticed the effect of this model, and the Canadian government and Canadian funders are trying to respond to figure out how we can adopt a similar kind of model here. It's going to happen. I have no idea what it'll look like, but I think it is going to change things. So I think one of the things that COVID-19 has done is it has changed the way we think about research. It has brought in new research models like the platform trial that I described. It has underlined both the possibilities for international collaboration, but also the extraordinary power that comes when you share data in Canada with data that's generated in Nepal. Generalizability and the speed of that data collection is improved. Critical care is being recognized by the World Health Organization as really on the forefront of a public health agenda, whether it's in pandemics or whether it's in antimicrobial resistance. And I think we're going to move into an era where we will, just as other industries do, we will see research as being a core element of what we do. In fact, one of my colleagues has talked about trying to convince the federal government to incorporate research as one of the pillars of the Canada Health Act. And I think that's an aspiration for those of us who believe the importance of research in looking after patients. So I think, I'm so privileged to have been able to be a part of some of this stuff, and so grateful to the PSI Foundation, because although there's still a long way to go in many, many different areas, those little bits of seed money really came at times where there was nothing else there, and where you could either succeed or fail, and being able to kind of carry on and actually take some crazy ideas and move them forward is really fundamentally important to the overall ecosystem of research. And so thank you so much for your support over the last 3 decades and for the privilege of speaking today.